If I make this card disappear, you have to click on subscribe button, okay? Keep watching, keep watching. In this video, I will cover the management of preterm labor, which is defined as labor that happens between 20 to 36 weeks and 6 days. The rate of preterm birth is about 12%, and half of those are preceded by preterm labor. Therefore, it's important to manage preterm labor effectively. Labor is defined as regular uterine contractions that cause cervical dilation or dilation of 2 cm at presentation. Risk factors include but not limited to history of preterm labor, multiple gestation, infections that include chorioamnionitis, pyelonephritis, periodontal disease, smoking, drug abuse, and low BMI. Let's talk briefly about fetal fibronectin test. Fibronectin is a glycoprotein commonly known as pregnancy glue. This test can be done between 20 to 35 weeks. It has a high negative predictive value, meaning if it is negative, it is very unlikely that the patient is in preterm labor. If a patient is diagnosed with preterm labor, it's important to assess the fetal well-being by monitoring the fetal heart rate. Performing an ultrasound scan allows the obstetrician to determine the presentation and the estimated fetal weight. Drugs that are used in preterm labor include tocolytics, steroid, and magnesium sulfate, and we will talk about those in details. Let's start with steroids. The most widely studied steroids are betamethasone and dexamethasone. It's recommended to be given between 24 to 34 weeks if a patient is in preterm labor. However, new evidence suggests benefit before 24 weeks and up to 37 weeks. Steroids decreases the incidence of respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, and it decreases mortality. Magnesium sulfate is an infusion that's given up to 32 weeks. It has a neuroprotection benefit, particularly in decreasing the incidence of cerebral palsy. Tocolytics are helpful in slowing down the contractions to buy time for the steroids to work or for in utero transfer to a higher level care. It is recommended to be given up to 48 hours. The first tocolytic is calcium channel blocker nifedipine. While it has no known fetal side effect, maternal side effects include dizziness, flushing, hypertension, and elevation of hepatic enzymes. It is contraindicated in hypertension and preload-dependent cardiac lesions. The second type of tocolytic is beta agonists. Maternal side effects include tachycardia, hypertension, tremor, palpitation, shortness of breath, and pulmonary edema. It can cause fetal tachycardia. It is contraindicated in tachycardia-sensitive cardiac disease and poorly controlled diabetes. The third type of tocolytic is non-steroidal anti-inflammatory drugs. Maternal side effects include nausea and gastritis. Fetal side effects include constriction of the ductus arteriosus in utero, oligohydramnios, patent ductus arteriosus in the newborn. It is contraindicated if the patient has platelet dysfunction, bleeding disorder, or allergy to aspirin. The last tocolytic is magnesium sulfate. Maternal side effects include flushing, nausea, respiratory depression, and cardiac arrest. It can also cause neonatal depression, and it is contraindicated in a disease called myasthenia gravis. Don't forget to check out my books on Amazon. One of them is called OBGYN Made Easy, Don't Waste Time on the Shell, The Pearl is Inside, and the other one is for questions and answers. And the links are provided below. If you want to support this channel, please like and subscribe. If you have any question or any suggestions, please leave them in the comments below and I will do my best to address them. Guys, my commitment to you is to provide you with the latest information based on the most recent American College of Obstetrics and Gynecology guidelines. Thank you and see you next time.